So a little shift in gear for the talk today, less technical, and kind of builds on what Alex talked about in his first talk this morning. So I'll just wanted to introduce the concept of pharmacologic treatment for spinal fusion, promoting spinal fusion in the osteoporotic patient. Just some background and definition. Osteoporosis is defined as a systemic disease characterized by low bone mass and microarchitectural deterioration of bone, with the consequent increase in bone fragility and susceptibility to fracture. And this is diagnosed either by low BMD on DEXA, T-score minus 2.5, or history of fragility fracture. Fragility fractures are defined as those that occur as a result of minimal trauma, so just fall from standing height or less. Bone mineral density, or BMD, which is measured by DEXA scan, determines approximately 60 to 80% of bone strength. And the DEXA scan is the gold standard to assess this. It's reported as a bone mineral content per square centimeter. It's used to diagnose osteoporosis, predict fracture risk, and to measure and quantitate your response to treatment. As Alex stated earlier, probably high-resolution peripheral quantitative CT may help us to better understand the microarchitecture of trabecular and cortical bone, but it's not always widely available. There's been a shift in the concept of bone strength in the osteoporosis world in terms of the paradigm. So BMD is one component of bone strength, but we also have to consider bone quality. And so that refers to the microarchitecture, the geometry, the turnover rate, so the homeostasis between bone remodeling and bone formation, degree of mineralization and properties of the collagen and mineral matrix. So this is where I think we can intervene with pharmacologic therapies. Osteoporosis is the most prevalent bone disease in the United States. It affects over 10 million Americans, and the incidence is only expected to increase in the next decade. It does burden our socioeconomic system, so over 2 million osteoporotic fractures occur each year. This results in over 500,000 hospitalizations, 800,000 ER visits, 2.6 million office visits, 180,000 nursing home admissions, and a direct cost to our system of over 20 to $22 billion. And just to put things into perspective, 1 in 2 women and 1 in 4 men over the age of 50 will have an osteoporosis related fracture in their lifetime. And so for women, the fracture incidence per year actually exceeds that of stroke, heart attack, and breast cancer combined. And for men, the fracture risk is higher than that of prostate cancer. So again, in perspective, over 50 million Americans with low BMD or osteoporosis in comparison to uncontrolled hypertension and hypercholesterolemia. So I think we're in a unique role as orthopedic surgeons and spine surgeons that we're often the first and sometimes the only physician to see a fracture patient in the hospital or in clinic. In this survey of over 3,000 orthopedic surgeons from 6 countries, 90% of orthopedic surgeons do not routinely measure BMD or DEXA after first fracture, and 75% actually report lacking the knowledge or the appropriate knowledge to treat osteoporosis. And more specific to spine surgery, this was a survey of over 133 spine surgeons. 44% routinely obtained DEXA scan before performing instrumented spinal fusion. I think this number has definitely gone up in the last few years with more awareness of osteoporosis in spine surgery. Less than 12% checked metabolic labs, calcium, vitamin D, and PTH, and 74% reported that they did so because it would change their operative plan. And 53% would refer a patient for osteoporosis management before spinal fusion if they diagnosed it by DEXA. But there still really is a significant treatment gap in terms of fragility fractures. It remains undertreated. 80% of patients with fragility fractures actually don't even receive a follow-up test or osteoporosis medication. And the actual number of prescriptions for osteoporosis medications actually decreased from 2002 to 2011. In terms of bone remodeling, this slide shows where several of our pharmacologic therapies intervene. So bone remodeling occurs in the basic multicellular unit within the bone remodeling cavity, and the important cells are, of course, the osteoblasts and the osteoclasts and osteocytes. Bone loss occurs in their 40s, and rapid bone loss occurs in women over the age of 50 after menopause, so with the loss of estrogen. So some of the cellular and molecular changes that you see are increase in osteoclast activity, a reduction in osteoblast activity, and then upregulation of several cytokines, IL-1, IL-6, a reduced activity of osteoprogesterone, and the rank ligand interaction. So these are, again, places to intervene in terms of therapy. So unbalanced remodeling occurs when resorption exceeds formation, and this results in net bone loss, most commonly with menopause in women age. Vitamin D deficiency, I think, is becoming increasingly recognized as a potential contributing factor, and then medications and other secondary disease states. So important to spine surgeons, probably the rheumatoid arthritis patient, chronic steroid use, gonadal insufficiency in men, and smoking. So the biology of spinal fusion occurs through primarily intramembranous bone formation at the decorticated transverse processes, but the central zone is low in blood supply, nutrients, and oxygen, and this is where enchondral bone formation typically occurs. So we're seeing an increased trend to perform more surgery in older patients. Osteoporosis is also increasing in our patients, and we just have to be cognizant of that. So over 1,000 patients undergoing spine surgery, 51% had osteoporosis, and that's in women, and 15% in males. So strategies to promote fusion. We know that BMD is inversely correlated with pedicle screw strength, and some authors argue that this is probably the most important consideration in terms of pull-out strength. Negative bone remodeling can cause delayed bone fusion, and non-unions negatively impact our clinical outcomes, but old age and osteoporosis are not necessarily contraindications to spinal fusion. So I just wanted to review some of the treatments available to us to promote spinal fusion. And this slide shows the FDA-approved therapeutic options for osteoporosis. So anti-resorptive agents include alendronate, risendronate, zoledronic acid, and raloxifene. And on the far right are our anabolic therapies, so which we talked a little bit earlier, Forteo or teriparatide, denosumab, and abaloparatide. So anti-resorptive agents are the most commonly prescribed agents. These reduce bone resorption, which improves your BMD, but we tend to see a plateau after several years. These include the bisphosphonates, which I'll talk about, and denosumab or PROLIA. And anabolic therapies upregulate your bone formation, so upregulate the osteoblast pathway. So just to review, bisphosphonates come in a non-nitrogen and nitrogen-containing form. The ones that we commonly use are alendronate, risendronate, zoledronic acid, which is Xgeva, and these are nitrogen-containing bisphosphonates which work through the farnesyl pyrophosphate pathway, and they suppress activity of osteoclasts, so just reduce bone resorption. This does result in improved bone mineral density by DEXA, and there's data to show that it reduces your vertebral and non-vertebral fracture risk by 40 to 70%. There's a theoretical concern that because you're inhibiting the osteoclast pathway, which actually is part of the spinal fusion pathway to start, alendronate may actually inhibit spinal fusion. In this study of a rat model, they reported a lower fusion rate of 50% in alendronate-treated animals versus 95% in control. Fusion masses in the alendronated-treated animals were radiographically by CT larger and denser, but when they looked at histomorphometric methods, they found that alendronate may actually inhibit bone graft resorption and incorporation. And in an osteoporotic animal model, by contrast, these authors reported improved osteogenesis and biomechanical strength of the fusion mass. And this was a randomized study of 40 osteoporotic patients undergoing single-level fusion, randomized to either alendronate versus vitamin D, and these authors found a higher fusion rate in the alendronate-treated group, 95% versus 65%. Xgeva, or zoledronic acid, is a IV-administered bisphosphonate. It's thought to be 10 to 15 times more potent than the oral bisphosphonates. These authors reported a higher fusion rate in the zoledronic acid-treated group, 90% at 6 months versus 75% and 92% at 12 months. And they also reported a reduction in adjacent vertebral compression fractures, 0 versus 5, and reduced pedicle screw loosening, 0 versus 6. And these are some mixed studies. So this one study out of Korea found no difference in the fusion rate or mass between autograft and allograft bone versus zoledronic acid. And another study, higher fusion rate in patients treated with zoledronic acid, 75% versus 56% at 2 years. A lower rate, similarly, of vertebral compression fractures, reduced pedicle screw loosening, and cage subsidence. I think the literature is kind of mixed in terms of the effect of bisphosphonates on fusion rate. So we definitely see an improvement in bone mineral density, and there's an anti-fracture effect both in the spine and the non-vertebral site, so the hip as well, but it may not necessarily be proportional to the efficacy on spinal fusion. Some think that this bisphosphonates may actually inhibit or delay bone fusion by uncoupling the balance between osteoblast and osteoclast activity, which is needed for bone healing. And there's some heterogeneity in terms of the method to define fusion. So some authors found no difference by manual palpation in the animal studies and radiographic studies, but histologically, the fusion masses were composed of more immature bone, unremodeled bone, more cartilage, and reduced osteoclast and osteoblast activity. So PROLIA, or denosumab, you may be familiar with, is a monoclonal antibody to the rank ligand, and it also works through the osteoclast pathway. So it's a reversible inhibitor of the osteoclast and inhibits bone resorption. This is also very commonly prescribed to patients because it's administered every 6 months. So patients really are on board with a medication that's given every 6 months. It has a shorter biologic half-life than the bisphosphonates. The fracture data is really strong, especially in the spine and the hip, but there's no literature in terms of its effect on spinal fusion in human studies or animal studies. And so what we discussed earlier was Forteo, or teriparatide, which is a recombinant N-terminal peptide of PTH. We know that PTH with constant exposure actually has a catabolic effect, but when you intermittently administer PTH, it actually has an anabolic effect and upregulates the osteoblast activity, which is necessary for bone remodeling, but it also does affect the osteoclast. So it really affects both pathways. It's indicated for moderate to severe osteoporosis, and histologically, it's been shown to improve the microarchitecture and the cortical thickness. Similarly, reduces fractures in both the hip and the spine. So again, constant exposure has a catabolic effect, but when you intermittently administer it and in a dose-dependent way, these authors found an accelerated rate of bone fusion, 89% versus 50%, and also improvements in the microarchitecture, primarily of trabecular bone. So that's important because that's the vertebral body and the distal femur metaphysis, and more modest effects on cortical bone. So this was actually the first randomized prospective study out of Japan. They looked at the effect of PTH in patients undergoing 1 and 2 level fusions for degenerative spondylolisthesis. Patients were randomized to PTH versus resendronate for a total of 10 months. So they were started on Forteo 2 months before surgery and maintained on it 8 months after surgery. They reported a faster time to union in the PTH group by about 2 months and a higher rate of fusion in the PTH group, both by CT and radiographs. The same authors did a follow-up study investigating the rate of pedicle screw loosening with Forteo, and they found a significant reduction in pedicle screw loosening in the Forteo-treated group. There were 3 cohorts in this study, patients treated with Forteo, bisphosphonate, and versus control. So they reported an overall screw loosening rate of 10% versus 25%, 27% in the resendronate-treated patients versus control. And this was a retrospective study which also found a significant reduction in the rate of pedicle screw loosening in patients treated with Forteo. They also reported a non-significant improvement in fusion rate in patients treated with Forteo. So the thought is that one of the mechanisms of how Forteo works is that perhaps it improves spinal fusion rates by positively affecting the implant fixation. So what about patients undergoing spinal deformity surgery? So longer fusions, this was also a study out of Japan, longer fusions greater than 9 levels with or without 3-column osteotomy. So this study, the patients were well matched in terms of the number of levels fused, type of scoliosis, treatment with or without VCR, PSO, or TLIF. And in the PTH-treated group, the authors reported a higher rate of facet fusion and total fusion. And again, a reduction in adjacent vertebral compression fractures, reduced rates of instrumentation failure, screw loosening, rod breakage, and improved clinical outcomes, both in terms of pain scores and disability scores. And this was thought to be related to the negative effect of complications associated with implant failure and adjacent vertebral fractures. And in another study out of Japan looking at proximal junctional kyphosis or failure, which we'll talk about later this morning, these authors found in 50 patients treated for spinal deformity, so more than 5 fused vertebrae with an UAV at T9 or T10, treated with or without PTH, they found improvements across the board in the adjacent vertebra above the construct in terms of volumetric BMD, bone volume, tissue volume, trabecular bone thickness, and trabecular number in the PTH-treated group, and a lower rate of PJK incidence in the PTH-treated group at 2 years, so 4.6% versus 15%. Forteo isn't cheap. Before it went generic, it could cost anywhere from $2,000 to $3,000 a month out of pocket without insurance coverage. So these authors were interested in looking at a weekly administration as opposed to a daily subcutaneous injection. So these were also out of Japan, 75 patients undergoing single-level fusion. The authors reported a higher fusion rate of 69% versus 35% at 6 months, and also a reduction in bone resorption and a higher increase in bone marker turnover, bone markers, so P1NP and CTX. And what about optimal duration? So when should we start our patients on Forteo? How long should we keep them on Forteo? This was a study that looked at duration. So short duration was defined as treatment with less than 6 months, and longer duration was greater than 6 months. And these authors reported an improved fusion rate and a faster time to fusion with the longer duration group. So on average over 13 months total on Forteo, 92% fusion rate at 7.5 months versus the short duration group, which was about 5.5 months on Forteo, 80% at 8.5 months, and 70% at 10 months with bisphosphonates. And finally, a small series. The thought is there may be an additive effect of combining therapies. There are studies that show that combined therapy definitely improves your bone mineral density on your DEXA. This was a study looking at a small series of osteoporotic patients undergoing fusion with Forteo alone versus Forteo plus PROLIA or denosumab. They found improved or increases in bone marker turnovers, improvement in BMD in the femoral neck at 12 months. And the combination group had a higher rate of fusion, 82% compared to PTH alone at 6 months following surgery. So to summarize, I think there is definitely literature to support that there's a dose-dependent improvement in spinal fusion rates in the animal studies. And histologically, these fusions were more mature with greater proportion of mineralized tissue and more robust microarchitecture. Daily PTH administration does improve your fusion rate and reduce your rates of implant complications, specifically pedicle screw loosening. But I do think there needs to be longer-term studies. These studies were only 2 years out, so we're probably going to get more long-term data, hopefully soon. On the horizon, just wanted to introduce some of the newer agents which are available to us. Abaloparatide, or Tymlos, was launched, I think, about 2 years ago. It's a PTH analog, a strong agonist of the PTH1 receptor, so it works through the PTH pathway. They have strong vertebral fracture risk reduction data, so 86% reduction in vertebral fractures, 43% in the non-vertebral sites. However, the effect on spinal fusion in humans still needs to be studied. This was the first animal study that was just recently published. So again, starting looking at a rat fusion model, they found a higher levels of bone formation marker osteocalcin, improved fusion mass, architecture on micro-CT, and a non-significant improvement in fusion rates compared to controls. And also, the newest one available to us is romosozumab, or Avinity. This is an anti-sclerostin inhibitor. Sclerostin is a glycoprotein secreted by the osteocytes, and it inhibits the Wnt pathway signaling and increases your rank ligand. So it's a monoclonal antibody to sclerostin, which is thought to induce osteoblast activity and new bone formation. Patients like this one as well, if you offer them a choice between Forteo versus Avinity, because this is administered once a month in the form of 2 subcutaneous injections. There's strong vertebral fracture data, so risk of reduction of your vertebral fractures is 75%. There are some cardiovascular side effects, so it's contraindicated with patients with cardiovascular disease. And some animal studies have shown that it does restore bone mass and bone microarchitecture. So I think this is one that I think will be interesting to look at because it does impact both the osteoblast and osteoclast pathway. So it's kind of shifting the homeostasis for bone remodeling toward bone formation. And another one that may be launched is a cathepsin K inhibitor. So again, I think we'll have more talks this morning and from previous in terms of our surgical techniques. Dr. Lenke shared with us, bigger screws, larger diameter screws. When you're preparing the screws, perhaps under tapping or not tapping, positioning of your screws, cement augmentation is an option also available to us. And what we heard earlier, kind of multiple points of fixation, so dispersing the load, doing more osteotomies, perhaps accepting a lesser degree of deformity correction, and as Alex showed us the case, so distal failure, so anterior column support at the lumbosacral junction with iliac fixation, and trying to avoid your construct ending at a kyphotic segment. So take-home points, osteoporosis is really common. I think it's now being more recognized and we're more cognizant of it. We need more high-quality, prospective, long-term studies. But in my practice, I tend to treat osteoporosis early and aggressively. So, thank you.